Hello, Professionally Integrated. Thank you for tuning in. I am so excited and relieved that this paper is done after literally years and I don't know how many hours. But I'm really glad to be able to give back to the healthcare community, and I think this is a paper that I truly feel is incredibly important for many reasons. One, we want to see what happens to our patient's neck and is there a difference. We want to be able to help these patients. We want to give them objective findings so we can understand what is injured, what's damaged, how we can help, and is it different than the asymptomatic population. So this paper, which we got titled Diagnostic Accuracy of Video Fluoroscopy for Symptomatic Cervical Spine Injury Following Whiplash Trauma. This is published in the International Journal of Environmental Research and Public Health, because this is a public health problem, right? Chronic neck pain, especially after crashes, costs millions or billions of dollars a year. So what we did is we took 196 patients. 119 were injured, 77 were uninjured, and they were including into the study. And we did 3 statistical models that demonstrated high levels of sensitivity and specificity. So basically what we did is we took patients that had neck pain of 6 weeks or more after a car crash, and we got other patients. This went through an IRB process of patients that didn't have pain that lasted any more than a week in their life, right? So someone who woke up was like, oh, my neck is a little sore, lasted 2 days. They were an asymptomatic individual if they were asymptomatic at the time. And then what we did is we did digital motion x-ray views on their necks. And we measured, I believe it was about 37 parameters for each neck. We read them, we measured them, and we did it blindly again, meaning the forensic group through Michael Freeman would send out videos. Most of these videos were from my office. We did use some other offices as well, so it's a multidisciplinary or a multi-office paper. And when we got an image, we didn't know who the patient was. We didn't know male or female, and we didn't even know if they were hurt or unhurt, right? We read those images, we measured them, we sent them back in, they would send them again, and we would do it again. And so 196 people, 37 parameters, doing it multiple times, right? Thousands and thousands of hours of looking at all this stuff. And then we wanted to see, one, are certified readers and radiologists good at reading this? Is it pretty specific? And what's the difference between an asymptomatic, uninjured patient and an injured patient? And the reason this is important is for a number of reasons other than what I already said. One, from the med-legal perspective, right? So med-legal. Dr. Katz, how do you know your patient's neck was injured in this crash? Obviously, if you're a member of Professionally Integrated, there's a ton of causation. But now if I did this image and I see this finding, I can now tell the percentage of likelihood that this person is hurt compared to the non-symptomatic individual. This, I believe, is one of the biggest biomechanical papers looking at full, true movement, true subluxations, and healthy necks to see what the difference is. So what we found is we looked at typically cervical VF or DMX. Studies include a lateral view of flexion extension. We looked at A to P open mouth, oblique flexion extension, A to P flexion extension. And we were looking at areas where the ligamentum flavum, the anterior and posterior longitudinal ligament, interspinous, supraspinous ligaments run to see the stability of those regions. Okay? Then what we did, if you can see here in this chart, we looked at lateral overhang of C1, C2, the periodontal space of C1, C2, translation at C2, C7, intervertebral angulation at C2, C7, spinous process engagement, spinous process coupled movement, facet gapping on oblique, and facet symmetry. So we looked at not just end ranges, we looked how did the joint get there? What happens in that mid-range? Is it symmetrical movement? True subluxations, right? When they tilt, did the spinous process move? Do we see that in the unhealthy individuals compared to the healthy individuals? We actually looked, instead of using 3.5 millimeters, most of the studies, and this is on Professionally Integrated, are now saying 2 millimeters. We even looked at 2 millimeters. With this study, what's important is we established a new normal for a couple of levels, C1, C2, and even somewhere in the mid-cervical spine, and we're going to get to that. So we looked at, if you look at spinous process engagement, we looked at the degree of synchronous movement between adjacent spinous processes during flexion to neutral. And then we looked at degree of coupled spinous process rotation with ipsilateral flexion and degree of separation at facet during maximum lateral flexion. Right? So we looked at how does it move. So if you're going to try to use this paper to just do an x-ray at end range, you're missing what this paper was about. I do not have any stock in digital motion x-ray in that company at all. But you should send out to get your injured patient image to see if they're hurt. Then what we also looked at is we looked at measurements, 0 to 2 millimeters, 2 to 4 millimeters, 4 to 6, and over 6 millimeters of lateral bending. We looked at C2 to C7 translation, looking at 0 to 2. Where do these patients fall? Is there a lot of instabilities in asymptomatic groups? Is there a lot of instability in car crash patients? We know clinically what we see, but we don't have anything to support that they do or they don't have instability, whether symptomatic or asymptomatic, until now. So some other things that we looked at here was we looked at the lateral bending, and you can see in this diagram here, it says left with the white line. This was normal, right? We looked at normal overhang. This also shows abnormal periodontal space, but then below it you can see with 8 millimeters of translation. We measured it throughout the end range and the mid range. This was one measurement that we looked at here. Now I'm going to show you what we looked at on flexion and extension. Again, the hard part about this was we're trying to show pictures when the study was based on movement on video. So we had to try to, the journal really wanted to see some pictures, so we had to try to do the best we could, because again, it's video. But you can see here we looked at C2, C3, where it stayed together in flexion, and then here's a picture where 5 millimeters it translates forward. Now let's get to the exciting stuff, and this is really fascinating. What we did was we looked at all the parameters that I just discussed above, and we broke it down, okay? So if you could see here's the diagram. That talks from starting at there's symptomatic patients of 119, asymptomatic of 77, and the p-values. Percentage of females, the mean age, and then down below the total abnormal VF findings as the mean. And then we broke down each level and then compared the percentage to what percentage of patients did we see this finding in the hurt group, and what percentage do we find this finding in the asymptomatic group? So we can see this person is 33% less likely, or 80-something percent. So let's just take, I'm not going to read it all to you, but I want to point out a couple of highlights, okay? So what we looked at, let's say here at C2, C7 translation on lateral, take a look at C5, C6. 19% of the symptomatic groups had abnormal translation, and only 2.6% of the asymptomatic, right? So 19 to 2.6. Let's take a look down below here at, let's say C7, C2 to C7 spinous process engagement. C5, C6, 25% of the injured group and 0% of the asymptomatic group had this. So we're seeing abnormal tearing and ligament disruption of that posterior column between the spinous processes. We're looking at coupled motion, okay? Let's take a look at facet gapping, okay? C5, C6 facet gapping on A to P. We found that in 37.9% of chronic car crash patients. Most of these patients have facet injuries. And what did we find on the at C5, C6, on the asymptomatic, 0%. Down at C6, C7, 1.3%, at 4, 5, 3.9% of the asymptomatic had it, but up to 34 to 37% in the car crash group. What does this mean? Well, you do a DMX, and through that movement, you see facet gapping at these levels. You could say, look, this person has it, and 37% of the asymptomatic group, or 37% of the car crash group has it, 0% in our control non-group had it. That's a huge statistical finding. So as you can see, some of the other findings that we saw here, we break it all down. So now let's talk a little bit about the uninjured volunteers had substantially fewer VF or DMX readings across all 37 combinations of measures and spinal levels. That was an average of 7 for 1.2 per patient in the asymptomatic group. But none of the uninjured volunteers had abnormal findings for 8 of the 17 of the measured parameters, and only 3 of the parameters were positive for abnormality in about 10% of the asymptomatic group. Okay, and that was at C1, C2, and 3-4 translation. There's a major difference between patients being injured in crashes and not injured in crashes. What we also found here is the likelihood that a patient with an abnormal C4-5 facet gap would be symptomatic was 44.9 times greater than a patient with a normal 4-5 gap. Meaning, you find C4, C5 facet gapping, that patient is 44.9 times more likely to have that finding than an asymptomatic individual. How do you know your patient's neck got a facet damage in a crash? Well, there's a ton of studies on this site that talk about facet injuries getting damaged, but now we have actually comparing it to the asymptomatic group, and if you find that facet gap with that sclerotogenous pain, maybe their head was turned, and you find that finding, that person is 44.9 times more likely to have a facet injury than an asymptomatic group. What we did here, I'm sorry, I know I'm biased, but this is awesome to help our patients. So let's talk a little bit with the total number of abnormal findings resulting in a model of an ROC of 0.94, which is really fantastic, indicating near perfect prediction in the training data. The odds that the subject was injured increased by 2.6 for each additional abnormal finding, okay? So you find 2 findings, then you find another one. That person is 2.6 more times likely, and then another 2.6 if you find it compared to the asymptomatic group. So the discussion here is, these results provide convincing evidence for several conclusions. 1, intervertebral instability is a common finding in the symptomatic population of patients with chronic neck pain after whiplash trauma. 2, intervertebral instability is an uncommon finding in the uninjured population. And 3, the findings of 2 or more abnormal parameters of intervertebral motion on DMX exam of the cervical spine is a highly accurate diagnostic test for identifying patients with chronic neck pain after whiplash trauma. That's published in the journal. You're going to copy and paste and put that in your notes and educate that you sending out for DMX, the DMX that you did, is highly accurate to determine these levels of instability, and the findings that you may find on an injured patient is incredibly common in car crash patients, but incredibly uncommon in non-car crash patients, okay? So these are some really fantastic findings that we know of. And now we have this, which was never done before. So I'm going to put this paper up here on the site for you to have full access to, and you can really read it, really look at what it shows. I'm not going to spend another 10 minutes explaining the rest of the findings, but I'm super proud of this paper, just like I was with the blood flow paper and some others. And again, to the members, the gold and premium members of Professionally Integrated, thank you so much for supporting this site. We didn't take funding to do this paper, and I really appreciate everyone who supports this group of what I think you see what our vision is, which is to help docs help more patients by just educating the community and the masses. And I think this paper clearly does that and is really going to help. So thank you all so much. If you have any questions, please comment in the site here, send me some messages, and let's get this out there. Let's start to show what we can do and how we can help these injured patients, and that there is a true difference. So thanks so much.